Everybody. I believe that we're live now. It looks like we have participants logging in as we speak. I'm going to be your moderator today. My name is Emad Talisman. Thank you for everyone who's attending on this wonderful Sunday afternoon, at least in Ottawa, Ontario. I'm not sure what it's like where you're at, but hopefully the weather is being kind to you. I'd like to extend my thanks. We're very grateful to Prison Legal Services, Schulich School of Law, the Elizabeth Fry Society, and John Howard Society for organizing this campaign and for inviting, I'd like to thank them for inviting me to moderate this important panel. If this is your first time on a Zoom panel, please note that you can pose your questions through the Q&A button at the bottom of the screen. You can pose your questions anonymously, so that option has been given to you if you prefer. We won't have the raise your hand option during this panel, but you can pose your questions at any time. And at the end of the panels, at the end of the presentations, we will address those in a Q&A session, which will be about 15 minutes, hopefully. Please feel free to like questions in the Q&A box. By doing this, it kind of gives us an indication of which questions take priority, and then we can focus on addressing those ones first. And we might not be able to address all the questions, but if I notice that certain receive a lot, then I'll pay attention to those. Okay, so let's get started here. I'd like to extend a very warm welcome and thanks to our panelists. So we have David Cloud from Unmet at the University of California, San Francisco, Andra Niculescu from the Association for the Prevention of Torture in Geneva, and Robert Patterson from the International Committee of the Red Cross, who is joining us from Tunis. My name is Emad Talisman, as I've said before, and I've been a policy and research analyst at the Office of the Correctional Investigator for almost 3 years now. To set the stage, I'm going to give a brief presentation on the use of medical isolation in Canada's federal prisons during COVID-19. So this is where I pray for technology to work. Use medical isolation. Okay. I can only see the panelists, so I just want to ask them to nod their heads. Can you guys see this okay? Looks good? Okay, very good. Thank you. Okay. If you tuned in during the, I'm gonna get right to here. So if you tuned in during the Correctional Investigator's presentation on Thursday, you would have heard some of this, but just for those of you who are unfamiliar, I'm first going to begin with a quick overview of our office. The Office of the Correctional Investigator is Canada's ombudsman for federally sentenced individuals. Federal sentences are those of 2 years or more. The OCI is legislated to provide independent oversight of federal corrections. We conduct investigations into the problems of federally sentenced individuals related to decisions, recommendations, acts, or omissions of the Correctional Service of Canada. So our focus then is on compliance, fairness, and legality. I'm going to speak to the use of medical isolation in Canadian federal prisons during COVID-19, but I think it's important to clarify that as far as we know, the practice of medical isolation began in response to COVID-19 and should not be confused with medical observation or other clinical monitoring practices employed by CSC. In fact, the creation of the medical isolation flag was announced in a CSC bulletin that you can see here, dated April 1st, 2020. Just some background. During the early days of the pandemic, the Office of the Correctional Investigator, the OCI, learned that CSC was placing both symptomatic and asymptomatic individuals in medical isolation. On April 23rd, in its first COVID-19 update, the OCI raised concerns about medical isolation in federal prisons. These concerns included near total cellular confinement and the denial of fresh air exercise. In its second update, the OCI reported that indefinite lockdowns or extended periods of cellular isolation at many facilities, even those that had not experienced an outbreak. In mid-July 2020, CSC promulgated or implemented its internal policy titled Medical Isolation and Modified Routine for COVID-19, or CD 822. This directive was provisionally promulgated without formal consultation. CSC claimed that this was due to urgent needs brought on by the pandemic. Nevertheless, the service reached out to the OCI and other stakeholders and committed to revise its policy once feedback was received. To date, however, CD 822 has yet to be revised. Our main concern with CD 822 was definitional in nature. Medical isolation is defined as short-term limitation to an inmate's movement to help prevent the introduction and spread of COVID-19. Given everything we've heard thus far during the campaign, the OCI's concerns regarding the conditions of confinement in medical isolation spaces, one might naturally ask, okay, who does this definition apply to? Are asymptomatic individuals included? How about new admissions and returns to custody, revocations, suspensions, for example? How long are individuals kept in this form of isolation? Now, I don't want to get too much into best practices here, as you'll hear more about that from other panelists, and David's going to be speaking after me about this more specifically. But just briefly, in our comments to CSC on CD 822, we cited a briefing prepared by the medical professionals and researchers from Unmet at the University of California, San Francisco. Specifically, we drew attention to the distinctions made by Unmet between quarantine, which is the practice of separating and restricting the movement of people who may have been exposed to a contagious disease until they are cleared by laboratory testing, medical isolation, which is the practice of isolating people when they show signs or test positive for COVID-19, and solitary confinement, which is a practice of isolating individuals while simultaneously imposing punitive measures and major restrictions to access and movement. Well, in contrast to the distinctions just presented, the criteria for CD 822 appear to apply medical isolation quite broadly. In addition to those diagnosed with or showing symptoms of COVID-19, the criteria also seem to include all new admissions, those who have been in close contact with others who had symptoms or diagnosis, transfers from external outbreak sites, and interregional transfers. In effect, everyone entering an institution seems to be a candidate for medical isolation. This problem is compounded by paragraph 3A of CD 822, which gives the institutional head, in effect the warden or his or her delegate, the authority to medically isolate individuals admitted on a new warrant of committal or returns to custody following a suspension or revocation. In all other cases, the institutional head can only authorize a medical isolation placement upon the recommendation of a registered healthcare professional. However, according to information recently obtained by our office, a number of inmates have been placed in medical isolation without prior recommendation of health services, even though they were not admitted on a new warrant of committal or return following a suspension or revocation, as per that paragraph 3A that I had mentioned. So our main concern is with the potential of medical isolation, as defined by CSC, to violate basic standards of dignity and human rights by imposing over-restrictive conditions that are not clinically justified. Are individuals placed in least restrictive environments? Is this an unlawful deprivation of the individual's residual liberty? Does the use of medical isolation amount to additional punishment for the incarcerated individual? Of course, to answer these questions, we would need to know more about the clinical benefits of employing medical isolation over other less restrictive forms, and whether and how medical isolation is substantively any different from other forms of segregation. The office is already aware, as many of you are through your own investigations or interactions with inmates and their loved ones, of their frequent non-compliance with statutory obligations during the pandemic. Rehabilitation programs, including Indigenous services and ceremonies, are restricted. Yard time, fresh air exercise is often denied. Prisoners are spending more than 22 hours a day in their cells. Visits have been limited, if not altogether stopped. Mental health services are inconsistent and overwhelmed. So there is ample reason to be concerned, to say the least. On the question of whether medical isolation is clinically justified, one way of inferring whether asymptomatic and/or presumptive cases are, in fact, being medically isolated is by looking at active medical isolation flags. And I don't want to overwhelm you with these numbers, but I think they're important in this context. On September 22nd, 2020, there were 376 active flags, but there were no active COVID-19 cases. On November 17th, 2020, there were 456 active medical isolation flags and only 22 active COVID-19 cases. On the same date, November 17th, CSC's public reporting also showed that 358 COVID-19 cases had already recovered, 29 were inconclusive, and 15 were pending. Unfortunately, we've come to learn that the medical isolation flags themselves are not completely reliable sources of data. CSC cannot confirm the accuracy of its active versus inactive medical isolation flags. In fact, we recently spotted one flag that was active since April, and when we followed up with the institution, they informed us that they had failed to deactivate it. The individual was released from medical isolation after about 2 weeks of placement and has since reached his warrant expiry date. Since the flags aren't being used properly, CSC also can't report on time spent in medical isolation. Given the pandemic lockdowns, it is also difficult for us to get a live picture of the conditions in medical isolation cells for the office to get that live picture, beyond what our senior investigators are able to learn from virtual calls to institutional staff. All that being said, more than 6,000 medical isolation flags have been assigned to unique offender ID numbers since March of 2020. Of these, almost 5,000 were issued to individuals in custody, including 75 in healing lodges. In light of the fact that roughly 4,800 inmates received the medical isolation flag at some point over the past 9 months, while around 3,500 COVID-19 tests were administered and 416 were found positive, one would be justified in asking, why so many flags? Administrative oversight, perhaps an overreach of administrative power, an overly cautious approach? If these numbers reflect actual medical isolation placements, where is CSC putting all of these people? For how long and under what conditions? Almost at the end here. So the OCI understands the need for temporary restrictive cellular confinement until laboratory results have been received. However, the application of these measures must not violate the basic standards upheld by the Superior Court decisions in Ontario and British Columbia, which found prolonged solitary confinement as defined by the Mandela rules unconstitutional. These standards were enshrined through Bill C-83 and include, though they don't apply specifically to medical isolation and they're for SIUs, I think it's important that we consider them: minimum out of cell time, regular health checks, meaningful human contact, external oversight and review, and access to programs and services. In conclusion, in our correspondence to the service, the Office of the Correctional Investigator recommended definitions to clearly distinguish between the practice of medical isolation and quarantine, including clinically relevant criteria where appropriate. Service standards, for example, time restrictions and response times, for medical clearance and the institutional head's authorization to discontinue medical isolation and quarantine. Time restrictions for quarantine and medical isolation with clear guidelines to allow for the extension of restrictions as per the advice of healthcare. A requirement that any stays in medical isolation beyond 14 days be flagged in the offender management system and be subject to the same level of review and oversight as those for structured intervention units. And basic expectations for conditions of confinement, including out of cell, yard, and shower time, access to video visitation, and healthcare visits. So that ends my presentation. I now want to give the floor to David Cloud from Amend, and he's going to speak to us a little bit more about the ethical use of medical isolation to reduce the transmission of COVID-19 in prisons. David, the floor is yours.
Great. Thank you, Mad. Can everyone hear me okay? Okay, great. I'm going to share my screen. One sec. Okay. All right. So thank you for setting all of that up. So for those of you who don't know, Amend is we're at the University of California, San Francisco in the School of Medicine, and we work all across the country to work on prison reform issues. And obviously for the past 9 months or so, we have been very heavily focused on COVID-19. A lot of our work has been focused on ending solitary confinement at the state level. So naturally, back in March, when cases really started to um, come on the rise, we were really nervous and immediately wanted to monitor and pay attention to what was going to be taking place with the issue of solitary confinement. So some things that I want to do today is to build off the last presentation um, in three ways. The first is really just to be really articulate about why imposing solitary confinement, as we know as a punishment, is harmful and can actually exacerbate the COVID-19 pandemic inside and outside of correctional settings. I'm going to spend a little bit more time unpacking just some definitions around quarantine, medical isolation, and then particularly trying to give some definitional clarity to what ethical medical isolation should look like in a jail or prison setting. And then lastly, I'm just going to briefly touch on a couple of action items that different stakeholders that have a responsibility to address this crisis should do, given their roles. Um, so back in March, we were really, like I said, bothered by, really worried is really the best way to say it. Just it wasn't a matter of if COVID-19 would make its way into the prison system in the U.S. and across the world, but when. And we were particularly worried about knowing the kind of architecture of the overcrowded prison system in the U.S. that, you know, to stem the tide of a disease that's transmitted the way COVID-19 is, we knew that people were going to have to be separated. And we were very kind of just aware that units that are used for solitary confinement would be the places that institutions would put people. So we started talking with some of our advocacy friends, some other stakeholders in the public health world, and looking around for standards. And there are some things with the World Health Organization. The CDC has a little bit of guidance, but speaking writ large, there was just a lack of information, a lack of standard, a lack of guidance for any good intentioned person who wanted to come look for guidance on what they should do in the wake of this pandemic to ensure that this disease transmission was slowed or prevented, but also that people's human dignity and their human rights were not violated. So we set out to write some guidance. Since there was nothing there, we just kind of put our heads together and tried to flesh something out, which I'm very pleased to know that Imad and his team have taken some of our guidance. So this is pretty basic, and I think everyone attending this web conference would get this, but this is something we want to communicate to people who may not understand immediately. Why solitary confinement will worsen the COVID-19 crisis? Well, one of the simplest ways to think about it from a public health perspective is that fear and lack of information is one of the most basic enemies of good public health prevention. So if there are practices or rumors or what have you that anyone who has COVID-19 or is expected of having COVID-19 is going to be removed from a general population area and placed in a setting that is known to be very punitive, then that's going to deter people from reporting symptoms and prevent the medical professionals in correctional environments from detecting COVID-19 cases. We've heard quite a bit of that. Our transparency and the oversight in the US is very kind of scattered and not great, but we've heard a lot of anecdotal and some kind of systematic reporting of this very thing happening, where people are just fearful that they're going to be placed in the shoe or in the box or in the hole, as it's often described. And so they're simply just not communicating if they spike a fever, if they're experiencing a cough. And for obvious reasons, that can lead to localized and pretty big outbreaks, which have happened all across the US in the prison system. And obviously, removing someone from their comfort and putting them in a place that is punitive, where they're deprived of, um, meaningful human contact, the ability to communicate with their families, etc. That's going to create and exacerbate the harms that we already know come with isolation and solitary confinement. And in some cases, I think this is culminated with other kind of inactions in the U.S. To create real tension between the staff and the incarcerated people in some institutions. And there have been reports of like upticks in violence, potential uprisings, people getting really, really scared, and chaos is will ensue in those circumstances. It also creates occupational hazards for correctional staff. So just because if an institution is going to use a solitary confinement unit for medical isolation, oftentimes they're really just using the space and not implementing all the things that need to go along with it. So it may operate like a unit, a solitary unit, that as it normally would, meaning that people may be escorted. The officers are coming cell to cell, having to cuff and have this really direct interaction with people that, um, one, could infect a person from staff to incarcerated person, but also from incarcerated person to staff. So those really close interactions that come with working in a solitary confinement unit could be kind of an unexpected but perfectly plausible route of transmission. So now I'm just going to unpack some definitional issues. So, one of the most important things we wanted to communicate when writing these standards was that people working in correctional settings need to understand the basic difference between quarantine and medical isolation. And Imad kind of did that for us briefly, but just to reiterate, quarantine is the practice of separating and restricting the movement of people who may have been exposed to a contagious disease for a period of time until we can determine whether that individual will become or does become infected. That's very different from medical isolation in the sense that with medical isolation, we know that a person is experiencing the symptoms or has tested positive, and therefore there's a decision to isolate them um, to prevent transmission to other people. People can be with COVID-19 can be medically isolated alone or together with other patients that have COVID-19 diagnoses via testing. And just very importantly, medical isolation by definition is not punishment. So we've created, in addition to writing a couple papers in the medical literature, a couple white papers, have created some infographics that we hope can be disseminated and useful to advocates, corrections officials, whoever's focusing on this. And I won't go through this piece by piece because I've already kind of done so, but I think when people are writing about this and talking about this in their communities, they need to have these kind of basic definitional um, segments broken down. So again, solitary confinement is punishment. That's its purpose. It occurs for often a long or indeterminate period of time. Medical isolation and quarantine are not that. One, their purpose is to reduce the spread of a disease, but also they have determinate periods of time that are determined by medical evidence and clinical assessments for medical professionals. The conditions in solitary confinement, as many of you know, are often unsanitary, poor temperature regulation, use of force, all of the things that we read and know about of what life is like for people in solitary confinement. Um, the conditions and ethical, if you're going to do medical isolation or quarantine ethically, should look nothing like that. It should be an environment that's sanitary. There should be a functional toilet, sink, soap, adequate lighting, proper ventilation, and comfortable temperature. Um, and again, with amenities, Ahmad started to get into this, but we wanted to make it very clear that this is a sacrifice that people are undergoing when they're put into medical isolation for the greater good. So that it's unacceptable that they would be deprived of things that can help that experience be as psychologically bearable as possible. So they should have free and enhanced access to things that are very basic: television, tablets, reading materials, canteen, nutritious meals. Just because a person is placed in medical isolation, none of those things should go out the window. And anything that can be done should be done to promote human contact while a person's in medical isolation. So in the US, we have these terrible fees that people have to pay to talk to their loved ones. We hope this is an opportunity for departments of corrections to, suspend those fees and make sure that people can talk to their friends and family while they're undergoing medical isolation. Um, I kind of use that slide to unpack my next couple, but again, this is really to do medical isolation ethically in a correctional environment. Um, there needs to be clear oversight by medical professionals. So these are not units that should be run by security. This is a situation where medical staff should run the show. That means that people should be afforded at least daily visits from healthcare and mental health care staff, and they have clear communication about medical isolation. Why are they there? How long can they expect to be there? When will they be tested next? What's the rationale for keeping them there? All those types of things that we would want, any person would want, um, to have communicated to them should be afforded to an incarcerated person. When appropriate, they should also have opportunity to go outdoors to get fresh air, um, enhance access to TV, and I've already kind of mentioned these other ones. Um, One of the big problems that we're facing here in the US that is just by nature of having such an overcrowded system with bad architecture is that one of the concerns is that people are using solitary confinement units that have very poor ventilation and unsanitary spaces. So any Department of Corrections that's using medical isolation should assess the space and be very clear that none of the conditions in that environment itself pose a threat to spreading COVID-19, but also just to the sanity and the well-being of the person who's undergoing medical isolation. Transparency and coordination with health departments. That's one thing that's been pretty poor here in the US, not just with this, but in general. There are some states that are reporting on their use of medical isolation, but by and large, we really don't know how frequently it's being used. We don't know how long people are being held in medical isolation. And so we are hoping for greater standards that could be written, not necessarily by the Department of Correction, but really by health departments and legislative bodies in the US to require data documentation and reporting. In the US as well, a lot of facilities just simply don't have the medical capacity that they need to implement ethical medical isolation protocols. So they don't have the medical supplies for testing. They frankly don't have enough people, enough nurses and things like that. So, we keep reading about, you know, military nurses and other workforce people being deployed from other states to kind of hotspot areas, but we're yet to see an example of when some of these staff would be sent to a prison system that's experiencing a significant outbreak to just make sure that people who are undergoing quarantine medical isolation are receiving good care. So this is, I think, my last slide, but this is just a schema that we created that if you know anyone who works in a correctional environment and needs a little bit of a decision tree on the process of medical isolation and quarantine after someone's tested, I'm not going to go through this point by point, but there are kind of clear decision points along this spectrum that we think is really necessary to put into standards and to put into a practice manual for people working in jails and prisons so that they know, how long, when is it appropriate to designate a person for medical isolation versus quarantine? How long should they stay there? When they're there, what type of amenities and services should they be provided? And when can they go home? Or go home, meaning, the general population, or in another ideal world, another setting. So some other things that should be done, we just want to iterate these main 5. First, this is really for anyone working in a jail or prison, is really about clear communication. I've said this before, but it's really basic kind of human nature and health communication in this instance to be very frank and clear with people and residents about what medical isolation is and if you're going to be placed there, again, how long you're going to stay, and what amenities you should expect to receive while you're there. I kind of hit all these already, so I don't want to be repetitive, but I do want to say, really, to the right half of this slide, that we were very hopeful at Amend and kind of the advocacy world in the US that, the elephant in the room with a lot of these medical isolation issues really come down to population and space to be able to do this ethically. So we're hoping that people in power, governors, departments of corrections, parole boards will still take the call seriously to release as many people as possible from crowded prisons to make this possible. So that would free up the space, the workforce, and really make it, at least plausible that they could implement some of these standards that we've created to the maximal degree as possible. So I'm going to stop there. Oh, and here's my contact information. You can jot that down.
Oh, perfect.
Yeah, thanks.
David, thank you so much. There was a question that was posed that I think can just be addressed right now from Willow Cats asking if David's Amend slides are they on the Amend website? If not, can they please be sent to attendees? And I think the answer to that is definitely. It's on the website for sure. Our office, or at least myself in my work that I do for the office, and also many of my counterparts and colleagues around the world in prison oversight, have benefited from the work that Amend has done, and they provide all of their infographics and decision trees and all of these things on their website, so it's very accessible.
All of that's there, and the paper that I mentioned is available. I can send it around, but it's open access, so you won't be, it's not behind any paywalls or anything like that too. So I can send all those materials along.
Amazing. Thank you so much, David. And good luck. We're going to hear from you again, hopefully in a bit, probably, but just for everyone to know, David's joining us from medical isolation himself. He unfortunately had a bit of a transmission into his family, so broke the barrier.
Yeah, it's a very authentic presentation today on medical isolation from medical isolation.
You're well prepared, I think, so you'll be fine. All right. Next is Andra. Andra Nicolescu is joining us from Geneva at the Association for the Prevention of Torture, and she's going to speak to us about the broader human rights implications of the pandemic. I'm really excited about this, given Andra's experience, years of experience on numerous international bodies and with the likes of Juan Mendez and so on. So, Andra, the floor is yours.
Thank you so much. Thank you, Emma. I hope you can all hear me well. I'm really happy to be here and very glad that this is the topic of our discussion today. It's a very important one in my field, which is torture prevention. So yes, I look forward to talking to you about to framing, like Ahmad said, to framing this issue of medical isolation in the broader international human rights law perspective. And especially towards the end, you'll see that I would like to really get to the crux of why solitary confinement, or at least prolonged and indefinite solitary confinement, runs afoul of the non-derogable international law prohibition of torture and ill treatment, and why it's important that we consider this when responding to the COVID-19 pandemic. So first of all, just to say that this pandemic, it's really been a test not only for our healthcare systems, but also for the strength of our human rights mechanisms and for the availability of civil, political, and social and economic rights across the spectrum. And of course, it's just during emergencies like these when human rights are most threatened and when people most need the protections of human rights mechanisms and systems, which is why this is such an important topic for all of us. And I think we've seen this threat at the domestic, regional, and international levels. And at the domestic levels, not just in Canada or the US, but also in many other jurisdictions around the world. So in the words of the UN High Commissioner for Human Rights, the success of public health responses to COVID-19 will very much be reliant on our ability to adequately respond to the public health danger while also respecting and protecting human rights. As the High Commissioner said, the coronavirus is undoubtedly testing our principles, values, and shared humanity. And we can already detect some of that from today's discussion. I'd like to point out, as I think it's already painfully clear, but it bears repeating, that the pandemic has also worked to deepen and worsen pre-existing human rights problems, and the way in which these affect the most vulnerable and the most marginalized members of societies. Unfortunately, we've also seen authorities around the world sometimes use responses to the pandemic as a means to excuse human rights violations, with governments pushing the limits of emergency measures in some cases. Things like limiting some freedoms, like the freedom of mobility or of public assembly. We've seen authorities sometimes weaponizing what might be legitimate restrictions in order to do illegitimate things like quash dissent or control the population beyond what is required for a public health response, and so forth. So certainly it's reasonable to expect that states will turn to some restrictive measures in looking to fulfill their duty to protect human life and the right to life in response to the pandemic. And these, of course, will be restrictions on the right to personal liberty, such as mobility, on the right to freedom of expression in some cases, for instance, in terms of stopping the spread of misinformation about the virus and so forth. But at the same time, there are obligations under international law that are non-derogable, or jus cogens, as we call them. And these are obligations that basically can never be derogated from, no matter the extent of the public emergency at stake. So chief among these, of course, is the prohibition against torture and ill treatment. So now, before turning to the issue of solitary confinement more specifically, and how it runs afoul of this prohibition against torture and ill treatment, and which will bring us to the issue of medical isolation, I'd like to turn to briefly return to the point that our responses to the pandemic generally must encompass and must focus on the persons who are most neglected by society. And the constituency that we're discussing today, persons deprived of liberty, whether in prisons or in other institutional settings, is a very important group. Such settings, like prisons mainly, and other institutional settings, whether they're, for example, other health facilities or social care facilities, they're places where human rights abuses and inequality and marginalizations and social patterns of discrimination are significantly magnified. And again, it's become, I think, painfully clear over the past months that prison management and oversight bodies have been in a very tough spot and are really struggling to deal with the magnitude of the virus and of the pandemic on top of the general challenges they face. So it was interesting, for example, to hear from David on the work he does regularly for me, and then to think about how that's been magnified in light of the pandemic. Let's see. So yes, in terms of just some notes on solitary confinement more specifically, I hope to just frame the discussion by going over some of the main international law principles on solitary confinement. So first of all, just to note that the practice within penitentiary systems is one that's global in nature and it's subject to widespread abuse. Solitary confinement is often imposed on prisoners for prolonged periods of time and for diverse purposes. It's also employed in diverse contexts, including prisons, administrative facilities, juvenile detention centers, immigration facilities, mental health institutions, and so forth. All places that can also be very heavily impacted by the pandemic, of course. When used under certain circumstances, solitary confinement may lead to the violation of fundamental human rights, including the right to personal, physical, and mental integrity, and may constitute cruel, inhuman, or degrading treatment, or even torture, as I'll outline in the next few minutes. So by way of some background, in 2011, The former UN Special Rapporteur on Torture, Juan Mendez, with whom I was working at the time, presented a report to the UN General Assembly on solitary confinement, wherein he defined the practice in accordance with what's known as the Istanbul Statement on the Use and Effects of Solitary Confinement as the physical and social isolation of persons who remain confined to their cells, so prisoners who remain confined to their cells between 22 and 24 hours a day. Although the specific form or context through which solitary confinement is applied, or even the name with which it is referred to may vary, the fundamental characteristics of the practice, is the absence of significant contact between the detainee and other individuals, and of the absence of contact with the outside world. Social isolation as one of the harmful elements, probably the most harmful element of solitary confinement, is contrary to the essential aim of the penitentiary system, which is to rehabilitate offenders and to facilitate their reintegration into society. So that's a very important aspect from the prison management perspective and from the criminal justice system perspective. Significant access to human contact, both within and outside of prison, including contact with fellow prisoners and with prison staff, prison staff who are not strictly dedicated to security functions, are also essential for rehabilitation and for the psychological health of prisoners. So also something that is eradicated when solitary confinement is used in a prolonged or indefinite way. So often in practice, as we heard, solitary confinement is applied in such a manner that that violates these principles, rehabilitative principles, and in a way that causes severe pain and suffering that often amounts to cruel, inhuman, or degrading treatment, or even torture under international law. And due to the prisoners' lack of communication when they are in solitary, as well as the lack of witnesses inside the prison, solitary confinement can also give rise to other acts of torture and ill treatment, which is also a common problem. So, I mean, medically speaking, I know we'll have a doctor speak to us right after this, but solitary confinement, of course, can produce adverse health effects in an individual after only a few days, which with a risk of serious and irreparable harm, increasing each day that is spent in confinement. Research on the effect of solitary confinement has revealed that certain psychotic disorders, including a syndrome known as prison psychosis, I'm quoting from the report here, so apologies in advance. I'm not sure if this language is completely up to standard, you know, in the disability rights community, so just to say that. So such syndromes whose symptoms include anxiety, depression, irritability, cognitive disorders, hallucinations, paranoia, and self-inflicted injuries have all been very well documented. And prolonged solitary confinement may lead to the irreversibility of such effects. So in this context, and given the fact that the physical and psychological harm associated with solitary confinement is often related to the duration of confinement, the special rapporteur in his report defined prolonged solitary confinement as any period of isolation which surpasses 15 days. So again, this definition was based on the scientific evidence that I cited, which clearly indicate that after 15 days of isolation, the harmful psychological and even physical effects manifest and may become irreversible. So as the most important conclusion of the special rapporteur's report was the fact that any solitary confinement lasting more than 15 days in and of itself amounts to cruel, inhuman, or degrading treatment, or even torture, and should be prohibited in all circumstances. This was a standard that was then endorsed and adopted by an international legal instrument known as the Nelson Mandela Rules, which Emad cited. Thank you for that. So these are standard minimum rules on the treatment of prisoners, which well, they existed before 2015, but they were updated in 2015. And in this update, the 15-day prohibition on solitary confinement lasting more than 15 days was included in 2015 in this instrument. So that was a big victory for the human rights community. So the 15-day limit in this sense serves as a clear point of departure from which solitary confinement no longer constitutes a legitimate tool for state use. While the use of short-term confinement can be justified in some circumstances, provided that adequate safeguards are in place, essentially in the international law under the Nelson Mandela rules, posits that prolonged use of solitary confinement can never constitute a legitimate tool for state use regardless of circumstances. And this is, I think, where we get into the very tricky question of medical isolation, this balancing, right, in the context of a pandemic. That's not to say, I'd like to note that it's not to say at all that solitary confinement that lasts fewer than 15 days never constitutes ill treatment or torture. The assessment of whether solitary confinement amounts to torture or other ill treatment should always take into consideration all the relevant circumstances on a case-by-case basis. These circumstances include, for example, the purpose of the application of confinement, the conditions under which it's applied, the length and effects of treatment, of course, as well as the subjective conditions of each victim that might make them more or less vulnerable to the negative effects. So to conclude, under international law, solitary confinement may only be used under exceptional circumstances and as a matter of last resort. International norms also do indicate that it should never, under any circumstance, be applied to children or to persons who suffer from psychosocial disabilities. I won't get so much into that, but I think it's also an interesting point given the I think what David was mentioning a little bit about, you know, the uncertainty and kind of the anxiety around the pandemic and right persons who have been diagnosed with COVID already. So just amplifying that. And in cases where solitary confinement is admissible or can be imposed in a justified way, its duration must be as brief as possible, must be announced and communicated properly to the individual, and minimum due process guarantees must be in place. Within prison systems, persons being held in solitary confinement must also be afforded effective resources for challenging the reasons and the duration of their confinement, and must be allowed access to legal advice and medical care. I think, yeah, I mean, I think I will leave it there also so as not to be repetitive, but I think just again to conclude by reiterating some words from the High Commissioner from Human Rights, who emphasized that, you know, this really is an important opportunity to address some key issues and to improve, right, to both act on a serious public health emergency and to improve responses from a human rights perspective. So as the High Commissioner said, if our response to coronavirus is grounded in the principles of public trust, transparency, respect, and empathy for the most vulnerable, we will not only be upholding the intrinsic rights of every human being, but we will also be using and building the most effective tools to ensure that we can ride out the crisis and learn lessons and protect the human rights of all people in the future. So thank you so much, and I look forward to the discussion.
Andrea, thank you so much. That was a wonderful presentation. And yeah, you're absolutely correct. It's a very tricky, I think a pattern is starting to slowly emerge in terms of a principle that is pretty familiar to all of us, but that, you know, even though the discussion here is about solitary confinement for the campaign, the concern is whether or not we're extending this definition of solitary confinement too narrowly. And not including things such as medical isolation and voluntary limited association and, you know, all of these different restrictive housing environments. So the trick is to tie those two things together very clearly in the minds of the decision makers and administrators to say, look, as the law applies here, it also applies here. So I think that's very important. Okay, so without further ado, because we are running low on time, but I think we should be fine here. I want to introduce Robert Patterson from the International Committee of the Red Cross, who's going to provide us with a little more insight about best practices for preventing COVID-19 transmission in prisons. Robert, I'm looking forward to hearing what you have to say.
Thank you, Emma. I will try not to disappoint. First of all, I'm going to try and find my presentation, which is just gone. So let's just see. No, that's not what I meant to share. Excuse me a second. Now this should. You saw it a minute ago. I'm sorry about this. Hang on a second. Open. Yes, that's what I want to do. I want to open this one. The computer's as quick as I'm this evening. Apologies. Right. So I think this is fine. Could somebody just nod at me, or just Emma, if you could, and just tell me that you can actually see what I'm presenting? Yay. Okay, so we can get started. So first of all, I'd like to say a big thanks for inviting me. It was strange when we started talking about this, and for the benefit of the audience, we had a pre-meeting to prepare for this. I found myself strangely excited, and this is going to sound utterly inappropriate. But the reason I did feel that when I still do is because, as has been said before, this COVID pandemic has hit us all for six. It's an unprecedented thing, certainly in my personal and professional life, I think in all of ours. It's affected everyone, but one thing which was said at the beginning of the pandemic, especially by well-to-do socialites, was that, you know, it was the great level and nobody is spared. Well, that, as we know, is utter rubbish. And the reason I'm so excited is actually positive. It's because it does principally hit the most vulnerable people in society globally. And the fact that we're all so involved, and that there are so many initiatives, including this one, trying to really get a grip on the problem, trying to understand where the main tension points are, what the main best practices, if there are any. I prefer to talk about good practices because at this stage I haven't really seen too many best ones, but I do find that really exciting and hopeful. So I'll just briefly go through what I'm going to try and cover. I'll try and do this quickly. Why I'm here, why are we talking about prevention, what sorts of prevention, what effects these prevention measures have had, what do we do now, and what do we do next. So to start with, why I'm here, well, basically it's not me, it's, you know, I'm here because I work for the ICRC. And just for people who don't know, ICRC is a humanitarian independent organization that is sort of really focused on situations of conflict and violence, and really tries to assist the most vulnerable in those contexts. We obviously work to have the respect for human life, health, safety, and dignity assured. And we do this through trying to have the international laws and norms upheld. And this applies most historically through international humanitarian law, but more and more international human rights law. We do this in detention because, of course, in terms of vulnerability, invariably the most vulnerable segments of society are either in detention or end up in detention at some stage. And I won't go into that too much, but that is clearly the case. And how we work is we endeavor to enter into collaborative dialogue and provide support to detaining authorities. Our work is based on access, actually getting into the place of detention, seeing the conditions of detention, and talking to people. And when I say people, I include, of course, prison staff, health staff, and custodial staff, and prison managers. But of course, and crucially, all this information is triangulated with interviews without witnesses, what we historically call les entretiens sans témoins. And so we'll all say ESTs and expect people to understand us. So with detainees, to really hear their version of the story. And of course, all of this dialogue is then compiled, priorities are identified. We have a multidisciplinary team, which I think is one of our strengths. I mean, of course, now monitoring bodies have these, but this was very central to our work many decades ago even. And with that, we tried to build up a complete picture of situation in prisons, conditions of detention and treatment. And we bring this back to the authorities in a form of constructive audit, if you like. I'm saying all this just so you can explain where I'm coming from and what I see is really the effects of things. And yes, we do base our assessments on what the norms and standards are, but then we obviously have to compare them with what we see in the prisons. And it's not just the international norms and standards that we have to take into account, it's the local ones. Because obviously, if we're talking about healthcare, which is my field, I'm not going to apply the Swiss standards of healthcare to a prison in Central African Republic, because that would be absurd. Just to give you an idea of the sort of context we've been working in, we've got an operational coverage currently of about 100 countries where there are obviously conflict and violence. That's our strong point. In those, we have 58 or so where we have actually healthcare and detention activities, which is, you know, when part of the team has, there's always a doctor or a nurse, but where we actually implement health support activities. And I mentioned that because again, what I'm going to present to you is not only perhaps more the sort of concrete stuff that we see, but it's also biased. It's biased towards countries in crisis. And these are the ones where the systems that you'd expect to provide services are working less well than they could or should. So why was prevention the main approach upheld universally when COVID struck with regards to prisons? Well, it's very obvious really, but it does bear saying secure settings are ticking bombs for outbreaks, right? This is due to three main points. The first two are universal, and this is because the inmate population is exquisitely vulnerable to ill health because they come from the least privileged sectors of society. Usually they've had less health education. They tend to have more rather negative health behaviors, and they have a burden of morbidity which is typically greater than a similar sized demographic profile in the community outside. And then of course all this is compounded by the characteristics of secure settings. So, you know, in the definition of health as per the WHO Constitution, health is a complete state of physical, mental and social well-being and not just the absence of disease. Well, you're not going to be having health if you're locked up in prison. So by definition, prisons are unhealthy. And then on top of that, they're generally overused, under-resourced. As we know, incarceration rates globally are going higher and higher. The capacity to house this population is not growing to the same extent, nor should it, but that's a separate issue. So as a result, you get tremendous congestion. And that clearly, when you're dealing with COVID, SARS-CoV-2 virus, whose mode of transmission is respiratory droplets primarily, well, this is obviously going to be an ideal breeding ground for such an illness. And then the sort of cherry on the cake of this sort of disaster is that unfortunately those groups in the population who are most prone to the worst outcomes, including death of COVID, are very much overrepresented in prisons. So it's men, because men are more prone. It's people with chronic illnesses such as high blood pressure, cardiovascular illnesses, chronic lung disease, and so on. And increasingly, it's older people in prisons, as we know. There's also, and as Bree Williams, David, knows very well, this is a growing problem everywhere. So this is why prevention was seen as the first thing to do, and it was an appropriate response, right? So what was done in practice? So there were prevention methods that were put in place to stop the virus from entering and from preventing its spread if it did enter. And of course, the first step was to prevent entry, which was through systemic screening on admission. Now, as per the Mandela rules, systematic medical on admission to prison should be a standard process. It serves a number of purposes, including helping to fight against torture by identifying it on entry. So including to this standard procedure, there should have been, there were efforts made to identify COVID. Now, at the very start, as you know, these more and more available diagnostic tests were few and not available. So what was put in place was a triage system based on temperature and a questionnaire. So a respiratory questionnaire and whether or not there'd been exposure. And if somebody was flagged by the screen, but was symptomless, they were put into quarantine, exactly as David described. If, however, they were symptomatic and or had had a positive test, then they would be put into medical isolation. Now, to prevent spread within once the person was admitted to, to prevent spread within a prison, this depended crucially on the fact that a case that would appear in prison would be timely identified and an appropriate response mounted in good time to avoid further contamination. And in both cases, then again, you would have to have appropriate triage and care, and either quarantine and isolation. Quarantine for the cellmates or the person who'd been in close contact with the case that had appeared in the prison, and isolation for the person with the symptoms. And then universally for prevention, this is infection prevention control measures, which requires materials, processes, and trainings, as well as restrictive regimes. So lockdowns for prison with very reduced and sometimes stopped contacts, visits from the outside, and so on, but also lockdowns within the prison with people being put into increasingly restricted, having to face exceedingly restricted movements within the jail. And that's on top of the ones who are already in quarantine or isolation. So what sort of effect did these prevention measures have? Well, frankly, we've seen it everywhere. They've all failed. But this isn't necessarily surprising, because prevention measures, especially when facing such a contagious illness, they will fail. Their purpose is to allow the health services to build up capacity so that they don't become overwhelmed, so that people who do develop the illness can get access to hospitals, as can anybody else who happens to be sick from anything else, as opposed to being the bottleneck in the hospital, and it spikes in numbers of unnecessary deaths, right? So the good news was, with these preventions, they were introduced early, but unfortunately, they remained unchanged. So the lockdowns remained as they were started, and there wasn't this build-up of capacity that one had hoped for, whilst time was being won by putting up the prevention measures, right? There were issues with availability of IPC resources early in the epidemic. You know, this COVID has shown up how interconnected we are, and suddenly there was no more PPE because a lot of it comes from China, and we all know what happened there. So the other issue that came to light was that, unfortunately, there was a lot of what PPE was made available, unfortunately, was not always used properly, because staff and inmate training was not necessarily done as it should have been. And this is a general point that we see in the context that we're working in. It's very easy, in a sense, to give hardware. It's all the software which is time consuming, which requires collaboration, which requires more intensive work and repeat trainings and so on. That doesn't happen. So you end up by having little impact and, in fact, wastage. And then, so as I said, once the prevention methods had failed and the COVID had entered the place of detention, then what? And this is what we've seen. There was a sort of a paralyzed, what do we do now response, whereas what should have happened, it's easy to give lessons, I know, but by gaining time, there should have been time to establish links with the health services and so on, but I'll come to that a bit later. So restrictive regimes and separation measures were put in place. And basically what we saw, these are on a spectrum of gradually increasing assaults on inmates' mental health. Now, I like to say this bearing in mind that everybody, I think, worldwide is facing a similar assault on their mental health. I'm a very privileged person in where I live and how I work, but I have to say I'm feeling very constrained, and I have moments of intense claustrophobia, which is weird, just because we are all under pressure from this. Now, as I said at the beginning, COVID is not a great leveler, and I'm amongst the privileged few. Inmates are facing, who are already in a difficult, I would say, environment. As said, this has suddenly got worse, and it's staying worse. There's no visibility as to when this will return to whatever normal will be, right? And what we're also seeing is a gradual spectrum, progression along a spectrum of infringements on inmates' basic rights, right? And unfortunately, the mitigation measures that should have been put in place to make these restrictions on their movements, on their freedoms, justifiable in a view because of the counterpart, which is protection of the greater number, well, these have not necessarily followed. So COVID has highlighted clearly the weaknesses in the health systems globally. I mean, we've exceeded 60 million cases and 1.5 million deaths approximately. And that's the general situation. And specifically what is shown is this still major disconnect between prison and national health systems. What we've seen in particular is that the standards and norms for the COVID response have not been applied, have not been aligned within the prison as they were outside. And this has resulted in breaches. If you have a set of standards in the prison which is different from the one in the community, the virus can and will and has found them and has entered. We've seen no adjustments in the measures taken, including the testing and the what you call restriction movements to the changing COVID-19 epidemiological profile. So if you're going to, as the stage of the epidemic changes, you should adjust your prevention measures to ensure that they remain optimally effective, and they've just remained standard from the start. And what we've also seen, which is very difficult, is there's been very little by way of available and especially actionable data. Again, linked to this gradual marked disconnect between the prison health service and the national health service, which means that we don't actually know what the situation really is. And we have some visibility, but not that much, because as I should have said earlier, we depend on access, and both from a duty of care perspective, so as not to risk putting detainees at risk, but also do no harm one, which is the institution's obligation to preserve the health of its staff. We've not been going in prisons as much as we usually have, so we don't have our own data either. But what we have noticed is not only a problem, shall we say, with respect to access to healthcare services for COVID, but a broad access to healthcare issue. In fact, just last week, it was a representative from the Global Fund who was saying that because of COVID, we're on the brink of losing a decade's worth of advances in healthcare generally, globally, right? So this is clearly a problem, and we've seen it in prisons. And there have been reports done by Her Majesty's Inspectorate of Prisons in the UK, which show that effectively care for primary healthcare problems has come virtually to a standstill. Only things that are still done, and this includes specialties, but also women in healthcare, but also eye care and teeth care. And in this day and age in the UK, which is, as you know, a rich country, the default dental act becomes pulling teeth as opposed to any other form of more expected standard of care. And this is due to a number of issues. I mean, fear of people to go to see their healthcare provider because they don't want to, they're afraid of getting COVID, but also healthcare providers being afraid to go into prisons because they don't want to get infected either. And then as well as the physical healthcare issues that I've mentioned too, we've really noticed an increase in mental health care needs, and this for both inmates and staff. And of course, and very specifically and critically, as a result of this widespread use of various forms of separation. So, yes, we've seen a grave and worsening impact on health across the board. It's recognized, but still largely unmet, because everybody's a bit stuck as to how to improve access to healthcare services at a time when in the community they're also overwhelmed. Again, I've said this before, but it does bear repeating, lack of data. We are not monitoring the situation in prisons. No one is. We don't really know exactly what the situation is, nor how to learn from it. I mean, what are the main issues that we should be addressing? We're seeing discriminatory practices in terms of access to healthcare outside. So if a prisoner gets sick, he will or she will probably be told by the local referral hospital, oh, we can't deal with you, we're overwhelmed from the community, right? So irrespective of his condition, somebody from the community who may be less sick will be admitted, right? So they're being discriminated against on non-medical grounds. And then, of course, what is not repeated enough is that if you do not control COVID in the places of detention, then you will not control it in the community or globally. Prison health is public health. So there's a real obligation to provide good healthcare to prisoners, both to respect their rights, but also to protect the greater community. So what now? Well, these are all the questions that people are facing now. And I think this particular talk is really useful in, what do people do now? How and when do you unrestrict a restricted regime to do it safely and securely? What will be the new normal? Until then, what adjustments need to be made? What are the lessons learned? So the challenges that we find are really about rethinking the basics. I mean, is the cure that we're putting forward through these prevention measures and through all that we've done against COVID, is this actually becoming worse than COVID itself? And I'm not saying it is. I'm just saying that we have to try and look at both sides at the moment, because you know, the measures that were put in place and that have remained as such in many ways are having very bad effects. The other thing that's a challenge is that there isn't a silver bullet, right? Everything is contextualized. It depends on the capacity, the strengths and weaknesses of the local healthcare provider, of the national health system, of the local prison. The personality of the director we've seen has a huge influence on how well or how badly detainees fare with respect to COVID and generally. Also, once the habits in terms of the current restriction regimes have been put in place, it's very difficult to change them, right? So to kick the habit of what we're doing now, it's not good, but what do we do? So why do we just continue what we're doing? And we don't have the data to guide us as to which, you know, what would be a good model somewhere, something reliable. And as I said earlier, so far, we've not seen really good best practices, but we have seen a few good practices. Particularly in terms of mitigations. For example, if people are put in long-term separation for suspected COVID, so up to 2 weeks, then how can you still ensure access for assessment of needs? And this has been attempted remotely, sometimes through the door. Clearly, this is just to illustrate that you can try to mitigate, but ultimately mitigation has its limitations and it's not good enough in the long run. The key consideration with respect to what now is really what I think it was David that stated this, you know, as stated by UNODC, WHO, UNAIDS, and OHCHR, sorry, their joint statement, overcrowding constitutes an insurmountable obstacle for preventing, preparing for, or responding to COVID-19. And this is really important. A health response to COVID-19 in closed settings alone is insufficient. It is a health problem, but the solution cannot be just a health solution. And the main key issue, and this was stated by David, decongestion, reduce inflow, increase outflow. Detention as the very last resort, alternatives to detention when possible. And if you're going to release people, do it safely, and so that you protect individual and public health, and make sure that you're releasing people within a fully integrated into the national COVID response. Now, I'll just speak very briefly because I have no idea, I've probably gone over time already and I apologize, but we've talked about, and this Andrea was brilliant about really talking about solitary confinement and helping really understand it. But what I want to do is, the countries that I work in are so destructured generally that we don't have such clear-cut situations, right? So, and this is my point ultimately. So separation by any name, it was useful in as much as it was at the very beginning a good way to try to manage and control COVID, but it always had risks. And what we're seeing now are the long-lasting negative health impact of this long-lasting separation. Because yes, you can have cutoffs and thresholds, so more than 22 hours per day and more than 15 consecutive days. But actually, at the end of the day, we are social animals and we need meaningful human contact. In fact, that's why solitary confinement as a punitive measure exists, right? It's one of the most severe, in its purest form, legal disciplinary measures that can be imposed in a prison, because it hurts in a sense, right? And ultimately, whatever name you give to it doesn't necessarily determine the human impact. And it's not understood. I put these two pictures. The first one really annoys me, right? So it's a joke, ha ha. Your Honor, my client wants to a lengthy period of solitary confinement. He wants to write a novel. I'm not sure whether this is supposed to be ironic or not, but certainly it's not. The reality is more what we see in the right-hand picture, which is very much, I find, more evocative of the reality of solitary confinement. Following Andrew's reminder, I just added a quick slide of some of the health consequences that we see in prolonged isolation, primarily solitary confinement, but more generally. It's hugely variable based its impact on the individual, right? It depends on the regime, the context, the individual himself or herself. But it's unequivocally unhealthy and within days. You don't have to wait for the 15. It can be very, very fast indeed. It depends on the individual and their general context. It's both physical and mental, and has long-term irreversible effects at times. So it's not it's not a joke such as the one shown here. That was a quick aside, and I'll be finishing up very quickly. What do we need to do now? We really need to ensure that whatever measures are applied in the prison are aligned with those of the community. And I use the term community because, as I learned whilst discussing with Ahmad last week, community, a huge country such as Canada will have different procedures in place in different provinces. So you need to make sure that within that administrative health area, the same procedures are applied. Otherwise, the virus will find a way in. We need to bear in mind that the response to COVID will vary according to, will have to be dynamic, right? Because it'll have to respond to the profile of the epidemic at that point in time in that place. And that currently in many countries, we've actually moved away from a prevention to a more cohabitation, which has changed the way the people with a positive diagnosis, with symptoms are managed, whether they all have testing or not. If you have an outbreak in a closed setting and you have a lack of testing resources, WHO says there's no point in testing everybody. Test one person. If that one person is positive, assume everybody else is, right? So this is just to say that you've got to apply the same rules as are appropriate to the community that the prison's in. There's a really important point, and I've left it to last, and I'm sorry, but testing strategy, right? So it's seen as a hope. I mean, certainly in many of the contexts we work, they're asking us, can you please give us the test? Then we won't have to put people in quarantine, because obviously quarantine and isolation, as David said, takes up space, and they just don't have it. This is really, really dangerous. Diagnostic tests are not screening tools, at least not standalone ones. They are made to confirm a diagnosis in somebody with symptoms. They are not made to exclude a diagnosis in someone who doesn't have symptoms. And there's a rather complicated way of showing this, which I'm quite unable to do right now, but I can give you the link to the very good BMJ article that does. So separation and some form of separation will remain necessary for preventing spread of COVID. The tension then comes from managing to find the best way to protect with some form of separation whose negative effects are as minimized as possible. And that is still very much an open question. And finally, in terms of the alignment with the community COVID-19 response, it's the vaccination strategy. Prisons should be prioritized. Prison staff are first-line responders. Prison inmates are exquisitely variable. And if they're not controlled, if COVID isn't controlled in prisons, it will not be controlled outside. Now, generally speaking, another going forward message is the need to strengthen the healthcare access across the board in prisons for all healthcare issues, including mental health care, and aiming for an equivalence of health outcomes and not just equivalence of health services, because you have a greater amount of morbidity in the prisons, therefore you need to give more services to reach the same outcome. And a really closer collaboration, intimate collaboration with the national health system, or at least the local health system, right? And I say that there's this debate over where should the stewardship of prison health lie? Which ministry should be in charge? Should it be the ministry in charge of health for the country, or should it be the detaining ministry? Personally, I believe it should be the National Health Ministry, simply because you're more likely to have rapid translation and standard adherence to the same protocols and practices. You can, of course, have a very effective system where the prison health is under another ministry, but that does require, crucially, not only close collaboration, but really timely, fast, effective collaboration. And that's not always obvious, particularly not in a crisis. But ultimately, it doesn't matter. What needs to happen is close collaboration, timely collaboration. And then in terms of lessons learned, we will need to do, and this is not the last epidemic that's going to hit us. That WHO has been very clear. For that, we'll need data, and we don't have it, and we need to find a way of getting better data. And one thing that we will need, because this epidemic has caught us all by surprise, and yes, there were many places did have emergency preparedness and response plans. None of them were up to it, really, at least in the context that we work in. I don't want to cast aspersions on anyone else. Final, I'm sorry, I've probably overrun. COVID-19 control requires global unity and solidarity. And this is true. And it's solidarity not only internationally, but nationally and with all segments of society, including most vulnerable segments such as prisons. And this is, the sentence itself is from, I won't attempt to pronounce his name, the Director General of WHO, Dr. Tedros. And finally, looking hopefully, this is a crisis. It's an opportunity for thinking things through and to better address them next time. So therefore, it is an opportunity for hope. A few references that many of them have been mentioned before. They're the ones I found most useful. And that's it. And I'm sorry if I've overrun.
Perfect, Robert. Thank you so much for that. I'm trying to pull together some takeaways from today's panels. We do have a few questions here. Before we get to those, I'm just going to say, like, overall, I think what I've taken away from these set of presentations is that, and maybe you guys can correct me if I'm wrong here, but there seems to be an ethical and clinical way, clinically informed way of doing medical isolation. It should not amount to solitary confinement. Thinning the prison population will ultimately reduce the burden of isolation measures on prisoners, and closer collaboration is required between prison services and national health bodies to ensure equivalence of care delivery and outcomes. Does that basically pull it together? I don't see my other panelists here, but do those hit the main points? You seem to have
summarized at least the 30 minutes of my endless warbling into like a sentence quite comprehensively. So thank you.
No, not at all. Is there anything else that the panelists would like to add to that as like the main takeaways from today's panel? I guess not. I'm going to look at the questions here. We've got KRM asks the question, have we seen an increase of in-custody deaths by suicide during the pandemic? And I imagine that this question is specifically concerning Canadian populations. David and Robert and Andrew, if you have other information, you can please go ahead and answer that. I actually don't have the data on this. I'm not sure. I'm sure KRM, if you were to write to the Office of the Correctional Investigator, that we could provide you with information, but I don't have anything on hand. Let's see here what we have. And Matthew Pringle, good friend from good friend of ours, Matthew Pringle, says, to what extent, and I think Robert, you answered this to an extent, but he says, to what extent has the ICRC's access to prisons at the national level diminished during the pandemic? Did the organization have to greatly recalibrate its approach to detention monitoring in the wake of the pandemic? Many thanks.
Yeah, sorry, I just showing up my newbie Zoom capacity. So I ended up by answering that in the chat. I tried to anyway. The point was, yes, it was a dual thing. Prisons on lockdown, that doesn't exclude us, on the contrary. And we were very reticent to go in ourselves. A, because we didn't want to risk introducing COVID. B, because we didn't want our staff to be exposed to COVID. And it's also very difficult, but not impossible, to have this real close contact with detainees when you're wearing PPE. So this really brought us to clearly identify the objectives for our visits. What are we trying to do now? Do we really need to do this? Can we do this now with the constraints that we will have to deal with? And if the answer was yes, then we would be very transparent with the authorities and with the detainees as to why we were coming in, how we would come in. So the PPE, including the gel and the not staying in a confined space and so on. And so in a sense, it was quite a useful exercise, because it really, sometimes we get caught into a bit, I think, like, we get caught into an activity trap. We do visits because we do visits, right? This was really forced us to think clearly what we were trying to achieve and to make sure that we had everything prepared so that we could achieve these objectives with minimal risk to anyone, and to be transparent that there is no zero risk, right? But that we were really going to try hard to protect everyone, including ourselves. I don't know whether that. So yes, there was a great substantial reduction of visits. There were a couple of months when basically we didn't visit. We would not go into the detention quarters. We kept going to the prisons. We would get some phone calls. That was done. We also organized in some prisons. We helped the prison authorities organize family link calls with detainees and their families, I mean. But now that's gradually, now we're regaining access again. There, I hope I've answered.
Very good. Robert, thank you so much. Okay, well, I see that we've gotten to the limits of our time. So unless any other panelists have any questions or additional things to offer, I think that we can wrap this meeting up. I appreciate everyone who attended. I know that a Sunday afternoon, especially in this glorious weather in Eastern Canada and Central Canada at least, is probably preventing many from attending live, but I'm sure many will be watching the video on YouTube later. So David, Andra, Robert, thank you.